Alright guys, so wow, ang ganda ng video, no? Buhay na buhay. Nagkaroon ako ng energy ulit kahit medyo pagod na. Alright, so guys, summary lecture for pediatrics. Most of this naturo na namin the past few days. I know you guys have been studying pedia, and for those who attended the lecture, a lot of this alam na natin na dapat. Pero we'll be giving a summary para mas madali niyong maalala, para mas magkaroon tayo ng recall dun sa mga most important concepts natin for pedia. Alright? Okay. Let's start. Neonatology, again, remember your EINC, remember the steps, remember your chronologic order, and remember why you do it. Okay. You have to dry the baby systematically first, 30 seconds, 5 seconds each. Face, head, trunk, back, arms, legs, to prevent hypothermia and also to stimulate the baby to cry, which is very important para huminga yung baby for respiration. Next is your skin to skin. Huwag kakalimutan, mauunang skin to skin bago cord clamping. Again, magde-delay ka muna except for cesarean section. Pag cesarean section, magpapalit itong dalawang ito. Mauuna yung cord clamping bago skin to skin. But for normal delivery, mauuna yung skin to skin. Duration is 30 to 60 minutes. Okay, 30 to 60 minutes. In the board exam again, the better answer would be 30. Okay? Sabi ng guidelines until after the first full breastfeed. Remember that this is for transfer of good bacteria, thermoregulation, which is very important, and it also increases breastfeeding success. Cord clamping is 1 to 3 minutes or pulsation stops, whichever comes first. Please do not forget that. It prevents anemia in both full term and preterm, but it also prevents brain hemorrhage, IVH in preterm. Non-separation of the mother and baby is also very important. It increases success and for thermoregulation. Okay? Dagdag nyo pa sa EINC, hindi ko yata naituro during the lecture, kailan pinapaliguan si baby. It's either 6 hours, yun yung lumang guidelines. Okay, baka yun kasi lumabas sa questions, 6 hours. Or ngayon, ang mas bago ng guidelines is after 24 hours. Okay, after 24 hours bago pinapaliguan si baby. Routine suctioning is not done. Delivery room temp is 25 to 28. Thermoregulated is 36.5 to 37.5. Low birth weight is less than 2,500 grams. Kasi pag very low, it's 1.5. Extremely low is 1,000. Late preterm is 34 to less than 37. SGA, remember the magic number 10. For LGA, it's 90th. And again, there are a lot of complications pag maliit yung baby and pag sobrang laki. Expected complications for LGA, remember birth injury, polycythemia, hypoglycemia, and jaundice. All right, resuscitation. Okay, detailed, very detailed and discussed during your video lectures. Your priority is again always airway. Okay, airway, breathing, then circulation. Remember the ventilatory corrective steps, Mr. Sopa. Check the mask, reposition the airway, suction, open the mouth. Baka kailangan nyo magtaas ng pressure, your PIP. And if hindi pa rin gumana, check if you need alternative airway, meaning intubation. Okay? When you do chest compressions, kailan? Pag yung heart rate bumagsak ng less than 60 beats per minute. Upon suctioning, the baby grimace, what is your APGAR score for reflex irritability? Sabi natin, ang grimace na salita, ang score niyan is 1. Huwag kakalimutan. Alright. Again, for newborn screening-related diseases, binanggit na rin natin to. Remember, galactosemia, kidney, liver, brain. Abrupt ang onset, mabilis. PKU, brain lang, mabagal, musty odor. MSUD, mabango yung amoy ni baby, mabango yung ihi niya. Brain lang din, puro neurologic yan, and usually early in onset. So sa tatlong to, si PKU yung gradual, mabagal. G6PD presents with hemolysis, hemolytic anemia, usually pag na-trigger ng oxidative stress. So may mga bawal silang kainin katulad ng fava beans. CAH, maraming types ng CAH, ang pinaka-common at sana yun yung tatanungin sa exam, it's your 21 hydroxylase deficiency. Normal at birth, ambiguous genitalia, but more importantly, it is sexual and somatic precocity, hyponat, hyper-K, and hypoglycemia. Again, go back dun sa chart, guys. Yung cholesterol papunta dun sa androgens, estrogens, papunta dun sa mineralocorticoids, saka dun sa glucocorticoid. Okay? CH, sabi natin, global developmental delay, macroglossia, huwag kakalimutan ang prolonged jaundice at delayed tooth eruption. Kaput versus subgaleal versus cephal. Okay? Superficial is your kaput, nasa scalp lang siya. Cephalomatoma is subperiosteal, sa ilalim ng buto. Okay? Periosteum, yung outer layer ng buto. Subgaleal is below the aponeurosis, rupture of your emissary veins. Dagdag niyo pa siguro dito, it's usually associated pag yung vacuum delivery. Okay? Tapos, characteristics. Okay? Kaput crosses the suture line. Skin color changes dahil mababaw siya. Cephal does not cross, no discoloration. Subgaleal, kumakalat sa batok, kumakalat sa muka. Pag kumakalat-kalat yan, that is subgaleal. Okay? Kaput resolves in 2 to 3 days, the rest in 2 to 3 weeks. Mas matagal. Kaput does not increase. Okay? Pag lumalaki yan, hindi yan kaput. Malamang cephal or subgaleal. Surgical conditions, early onset, frothing. Okay, giveaway yan. Frothing, exacerbated by feeding. Pag naglagay ka ng NGT, hindi siya nagpa-pass down. Again, the most common type is your type C. This is your TEF, esophageal atresia with TEF. Again, type C. Remember, okay, esophagus ends in the blind pouch with a distal TEF. Blind pouch ng esophagus, distal TEF. Okay? Difficulty of breathing, scaphoid abdomen. Okay? Ang bata, pag nahihirapang huminga, lumalaki yung tiyan. Ito, scaphoid siya. Okay? Paradoxical. Tapos, bowel sounds. Pag nag-auscultate on the chest, think of your congenital diaphragmatic hernia. Okay? The most common type is your Bok-Dalek. Again, madaling tandaan sa anong location. Bok-Dalek hernia, back the left. Okay? Nasa likod, posterior, nasa left. Okay? Eviscerated content, may balot, may sac, midline. Associated with other anomalies dahil nga midline siya. Think of omphalocele. Okay? Stormy clinical course, binigyan ng pagkain, lalong lumaki yung tiyan at pumangit. Okay? You look for pneumatosis intestinalis on x-ray, and pag may perforation, pneumoperitoneum. This is your necrotizing enterocolitis. Okay? Omphalocele may sac. Ano yung counterpart niya na walang sac? Nakalabas din yung bituka. That is gastroschisis. Okay? Omphalocele is midline, gastroschisis is lateral. All right? Lagi kong sinasabi sa exam or sa review, early onset bilus vomiting, preterm, tapos hindi lumalaki yung tiyan. Okay? Preterm, early onset bilus, may obstruction, pero hindi lumalaki yung tiyan, walang ibang iisipin, this is duodenal atresia. Okay? Remember, urine output in neonates should be present within 24 hours. Meconium should be passed within 24, maximum of 48 hours. Okay? At pag meron kang delayed passage of meconium, what comes to mind? One of your top differentials should be your Hirschsprung's disease. Okay, Hirschsprung's disease. Pag delayed passage of meconium. Respiratory conditions in the newborn, sabi ko sa inyo guys, kailangan alam natin itong mga to by heart. Surfactant is present in the fetal lungs by what age of gestation? That is 20 weeks. Okay, detectable in the amniotic fluid at 28 to 32. But the most important figure, mature levels is reached at 35. So anything below 35, you expect that the patient might develop RDS. Surfactant reduces the surface tension. Pag walang surfactant, nagko-collapse yung airway. Okay? Mataas yung tension between the alveoli. So paglabas ng hangin during expiration, pak, nagsasara siya. Cessation of breathing longer than 20 seconds or any duration. Kahit 5 seconds lang kung nagkaroon ka ng cardiopulmonary compromise. 5 seconds pero nag-bradycardia. 5 seconds pero nag-desat. That is what you call severe apnea. Is apnea more common in preterm infants? Yes. The most common cause of idiopathic apnea is prematurity. Okay? Because your respiratory centers are not yet developed. Dok, anong ginagawa pag prematurity na apnea? Hintayin mo lang na lumaki yung bata. Hintayin mo lang na mag-develop yung respiratory centers. Okay? At habang hindi pa siya nagde-develop, you can give your methylxanthines, your theophylline, your caffeine, and aminophylline. Okay? Respiratory distress is more common in preterm. Please remember that, but it is not exclusive. On X-ray, you look for your ground glass opacity, underinflation. Very important. Okay? Bihirang-bihira yung takipnik na underinflated. So ito, underinflation. And atelectasis. Again, bakit underinflated? Bakit atelectasis? Because of collapse. Airway collapse, because of high surface tension, because of the deficiency of surfactant. Okay? Clinical presentation. Early onset. Premature. Grunting, prominent grunting, does not respond well to oxygen supplementation because you need your positive and expiratory pressure. And it progresses in the first 3 days. Okay? Management is prevention. Of course, prevent preterm delivery. Give steroids kung talagang hindi ma-prevent. Kung nandiyan na talaga yung RDS, surfactant, and your positive and expiratory pressure. Transient takip niya, on the other hand, is more common in cesarean section, delivered baby na full term. Okay, cesarean section, very important. Hyperaerated lungs, prominent vascular markings dahil ang problema nga natin is fluids. Hindi pa niya malabas yung fluids sa kanyang lungs. Early onset, quick recovery. Transient takip niya, benign. Okay, responds well to O2. 1 to 2 LPM pa lang, medyo okay na. Management is supportive. Okay. Jaundice in the newborn. Bilirubin used to determine your management in your Botany chart. Okay, remember Botany chart, you plot there kung kailangan ng phototherapy. Ang ginagamit natin is total. Okay, we're not concerned with the breakdown. We look at the total. The most common cause of jaundice in newborn is physiologic, but remember, this is a diagnosis of exclusion. Which part of your bilirubin crosses the blood-brain barrier? It is lipid-soluble. It is your B1. Okay? Other names for B1, it's indirect, it's angioconjugated. So, wag pagpapalit-palitin. Okay? So, again, indirect bilirubin, unconjugated B1. Okay? Direct is your conjugated, it's your B2. Okay? Treatment for jaundice, most of the time, it is indirect, it is phototherapy. The mechanism of action is photoisomerization. Okay? It converts your bilirubin into isomers that are less toxic and more easily excreted. Okay? Duration of physiologic jaundice, for most cases, less than 14 days. Okay? Less than 14 days. Yan yung cutoff natin. Okay, review. Physiologic or pathologic? Jaundice within 24 hours of life, pathologic. More than 12 ang bilirubin, pathologic yan. More than 2 ang direct, pathologic yan. Breastfeeding or breast milk jaundice, this is physiologic. Okay? Mothers O, babies A, Coombs test positive. Ano yan? Pathologic jaundice. Okay? Mothers O, babies A, jaundice on the second day of life, otherwise well, bilirubin is 4, this is physiologic. Okay? Bakit? Huwag malilito. Dok, may setup. May setup tayo. O si mother, A si baby. Kahit may setup yan, kung wala namang hemolysis, hindi lahat ng may setup, hindi lahat ng ABO magkakaroon ng hemolysis. Okay? So kahit may setup, hindi naman nag-jaundice si baby ng pathologic. Okay? Second day yung jaundice niya, well yung baby, tapos 4 lang yung bilirubin, then physiologic pa rin yan. Malinaw? Again, hindi lahat ng may setup magkakaroon ng ABO hemolysis, ABO incompatibility. Breastfeeding is earlier onset. Pathophysiology is inadequate calorie. So on history, yung mother nagbibigay ng milk. Management is, okay, increased feeding. Maximum duration is 2 weeks. Pag breast milk, mas nahuhuli. Mauuna ang F bago M. Okay? 7 days. Lumalabas yan. Glucuronidase. Okay? Sabi nila, unknown, idiopathic. Pero theory, glucuronidase. Duration, it's the only physiologic jaundice that can last more than 3 months. Management may stop. Kung masyadong mataas, mag-stop. Kung hindi masyadong mataas yung bilirubin, pwedeng hindi mag-stop. Okay? Let's now go to nutrition. Okay? Watery, high lactose and protein versus itong isa, creamy, high fat. Yung nauuna, yung watery, siya yung fore milk. Yung nahuhuli dahil malapot siya yung hind milk. Majority of the calories will be in the hind milk, kaya nga fat. Diba? Mataas ang calorie ng fat. Tinanong sa exam, protein that triggers your cow's milk allergy. Ano yung nagtitrigger ng cow's milk allergy? It is your casein. Predominant in breast milk, whey or casein. Anong gusto natin? Mas gusto natin mas mataas yung whey. The magic ratio is 3:2. Again, bodybuilders ang iniinom niyan whey. So that's how I remember it. Absolutely contraindicated in breastfeeding ang galactosemia? Yes. What about TB and breastfeeding? Yes, contraindicated but not absolute. After 2 weeks of appropriate treatment, you may breastfeed. What about HIV? Yes, contraindicated. Pero sabi, if you cannot avoid it, walang ibang pwedeng ipakain sa baby, pwede. Make sure it is exclusive to avoid gastroenteritis, okay? And least duration possible. These 2 qualifiers makes your transmission less, okay? Pag nagkaroon ka ng gastroenteritis, tumataas yung transmission kasi nasisira yung intestinal mucosa. Micronutrients. Difficult to treat eczema, diarrhea, dermatitis, low alkaline phosphatase. This is zinc, acrodermatitis, enterohepatica. Rachitic rosary, Harrison's groove, wind-swept deformity, softening of the bones. Yun ang kailangan tandaan. This disease presents with softened bones, vitamin D, rickets, osteomalacia. Scorbutic rosary, irritability, fever, perifollicular hemorrhage, cheilosis, and glossitis. This is your scurvy. Meron din siyang rosary, scorbutic. It is more sharply angulated compared to your rachitic. How do you prevent hemorrhagic disease or your vitamin K deficiency bleeding, VKDB? You give your vitamin K prophylaxis. Okay? Minerals in the breast milk that are dependent in maternal status. Sabi natin gold standard ang breastfeeding. Iilan-ilan lang yung minerals na bumabagsak yung content kapag deficient si mother. Dalawa lang. Vitamin D and iodine. Okay? Breast milk minerals where your fetal stores are enough for the first few months, for the first 6 months. Zinc and iron. Okay? Pathophysiology of malnutrition, severe acute malnutrition. This is what we call reductive adaptation. You try to survive. Okay? The body tries to survive. Hindi priority ang growth and development, hindi priority ang infection control or production of antibodies. Ang priority ng katawan is mabuhay. So, ang tawag doon, reductive adaptation. Measurements used to determine malnutrition. You can check your weight for length or BMI, or you can check your MUAC, mid-upper arm circumference. Okay? Protein energy. Ang kulang is protein. Moon fasces, fatty liver, severe anemia, neurologic deficits. Ano yan? Kwashiorkor. Mas toxic siya kesa sa marasmus. Marasmus presents with old man fasces, walang edema, decreased subcutaneous fat. Butot balat yung bata. The hallmark of refeeding syndrome is, ano yan? It's severe hypophosphatemia. What other electrolytes are deranged in refeeding syndrome? Hypo-K, hypomag. Pero ang hallmark, hypophos. Okay? The pathophysiology is your insulin. Because of the surge of insulin, okay, nagkakaroon ng transcellular shift. Kaya bumabagsak yung mga electrolytes. Again, remember, this is the reason why dapat cautious feeding, dahan-dahan ang feeding sa mga severely malnourished patients. Okay so far? Okay lang yung pace natin, guys? Pa-thumbs up naman dyan. Okay lang ba yung pace? Pwede ba sila mag-thumbs up? Hindi sila pwede mag-thumbs up. Okay, alright. Okay, may mga thumbs up tayo. Let's go to immunization. Okay, immunization and MC. O, tanong, can it be given simultaneously? Hep B and varicella? Yes. Varicella and measles, pneumonia and oral polio and rotavirus, MMR and Japanese encephalitis. Again, wag nang mag-isip. Okay, wag na mag-isip. Pag ang tanong sa inyo, pwede bang ibigay simultaneously on the same visit? Ang sagot, yes. Except for yellow fever and cholera. Okay? Interval, if not given simultaneously. Hep B and pneumonia, may interval ba? Wala. Varicella and chickenpox, parehas na live. Pag parehas na live, kailangan mag-antay ng 4 weeks. Again, ang premise is hindi mo nabigay ng sabay. Pwede siyang sabay. Pero pag nag-varicella ka, tapos hindi mo nabigay yung chickenpox, 4 weeks muna bago ka makapagbigay ng live ulit. Okay? Oral polio and rotavirus, okay lang, wala. Yung 4-week rule, only in live parenteral. Okay? JAP and oral polio, wala. Hib booster, kailan binibigay? Sabi natin, bakuna, 6, 10, 14 weeks. EPI schedule, 6, 10, 14. Booster usually at 1, booster usually at 4. Hib booster is given 6 months from the 3rd dose. So specific yung recommendations dyan. Varicella is given 3 months from the, pakipalitan to, dapat to 1st dose. Okay? Your 2nd dose of varicella is given 3 months from the 1st dose. But again, may asterisk yan. As long as you are able to give it, okay, 4 weeks apart, that is already acceptable. Meaning counted na siya. Okay? So ang Hib natin, example, sabi natin Hib, part of your penta, 6, 10, 14. Kailan ang booster? Dapat after 6 months pa. Eh, Doc, paano kung 6, 10, 14? Tapos nag-booster na ako ng after 4 weeks, 18. Counted na ba yun? Theoretically, yes. Okay? Kasi ang ating bare minimum is 4 weeks for most vaccines. Okay? AGE, most common etiology in children, bata, nagtatae, walang dugo, rotavirus. Bata, nagtatae na may dugo, ang unang iisipin, Shigella. Okay? Irritable, sunken eye, drinks eagerly, very thirsty. No signs, some signs, or severe? Some signs. Management of some signs, treatment plan B, 75 ml per kilogram of your oral rehydrating solution. And your reformulated ORS has a osmolarity of 245. Sodium and glucose ratio is 1:1, 75-75. Okay? And the macronutrient and the micronutrient that we give, okay, for AGE is your zinc. We give it for 2 weeks. Okay? Decreases vomiting, decreases diarrhea, also prevents further episodes of diarrhea in the next 2 to 3 months. So it's also protective. Okay? Let's go to growth and development. Okay? Important things to remember. Birth weight doubles in 4 to 5 months. Pag sa exam, may choices na 6 months, wala yung 4 to 5, tapos 6 months yung nasa choice, pwede rin 6 months. Triples at 12 or on the first birthday. Social smile is 2 to 3 months. Rolling over is 4 to 5 months. Babbling is 6 months. Okay, remember babbling? Consonants. Bababa, mamama, papapa. Pag wala pang consonant, pag a, e, i, o, u, vowels lang, ang tawag doon cooing. Cooing at 2 to 3 months. Object permanence, favorite na tinatanong sa exam, 9 months. First words, walks without support. Malamang ilang taon to, nagsasalita na siya, naglalakad na walang support, probably 12 months. Okay? This reflex is elicited by sudden movement, loud noise. Okay? So I think nasa question sa isang mga quiz nyo yan. So pag biglang nagpalit yung temperature, biglang lumamig, okay, nagulat si baby. Basically, this is your startle reflex. Okay? Describe as symmetric extension, abduction of the fingers and upper extremities, followed by flexion and crying. This is your Moro reflex. Okay? Deficits in socialization plus repetitive behavior. Ano to? Autism or ADHD? This is autism, ASD. Ang ADHD, impairing levels of inattention, disorganization, hyperactivity, and impulsivity. So, huwag pagpapalitin yung dalawa, very glaring naman yung difference nila. Alright? Profuse, rice, watery diarrhea, voluminous diarrhea. This is your cholera. The drug of choice is either tetracycline or doxycycline. Alternative is azithromycin or cotrimoxazole for less than 9 years of age. Okay? Kasi yung doxy sa yung tetra, meron silang age na hindi pwedeng ibigay pag mas bata. Okay? Prolonged fever, abdominal pain, diarrhea, meningismus, rose spots. Anong sakit yan? Prolonged fever, tapos GI symptoms, tapos non-specific, nakakalito, may seizure, may carditis, merong ano pa ba iba? Nephritis, okay? This is your salmonella, okay? Salmonella. The drug of choice for salmonella that is fully sensitive and uncomplicated, you can actually give chloramphenicol. But empirically, if wala ka pang culture, we usually start with your 3rd generation cephalosporins, ceftriaxone and cefotaxime, because they will cover for both your quinolone resistant and your severe typhoid. Bloody stool, tenesmus, pus, McConkey agar, xylose, lysine, deoxychocolate, or your SS agar. Ano to? Okay? Sabi natin, bata nagtatae walang dugo, rotavirus. Bata nagtatae na may dugo, unless proven otherwise, this is Shigella. The drug of choice is ciprofloxacin. Okay? Other drugs, sabi ni Nelson, pwedeng cefixime. Okay? Cefixime. Pero again, WHO tayo pagdating dito, the drug of choice is ciprofloxacin. Okay? Obstruction. May bara yung bituka. Okay? Again, ano yung mga question na tatanungin if you want to rule out obstruction? Onset. Pag early onset, baka may obstruction. Bilus ba yung vomiting? Pag bilus vomiting, baka may obstruction. Lumalaki ba yung tiyan? Saka hindi siya dumudumi. Pag lumalaki yung tiyan at hindi siya dumudumi, baka may obstruction. Okay? Okay. Currant jelly, paroxysmal pain. Sobrang sakit, pero in between, okay yung bata. Severe pain, knee flexing, flexion of the knee. Okay? Namimilipit sa sakit. Tapos may sausage-shaped mass. Ang description, you have a portion of your alimentary tract that is telescoped into the adjacent segment. This is your intussusception. On ultrasound, look for your donut ring or your target sign. Okay? Erythromycin used during neonatal period. Ito, hindi ko nabanggit to ng lecture. Okay? One of the risk factors for developing this disease is using your erythromycin. Kaya bawal yan sa neonates. Okay? It presents with postprandial vomiting. Meron kang firm, palpable mass. Ang shape ng mass, olive shape. This is your pyloric stenosis. On barium, look for your shoulder sign and your double track sign. Absence of your ganglion cells, constipation, delayed passage of meconium. This is Hirschsprung's disease. On imaging, you can look for transitional zone or ano pa yung ibang pwedeng makita, bird's beak. Okay, bird's beak sa colon, sa baba. Biopsy findings, the diagnosis is your suction, rectal biopsy. Finding is aganglionosis. Painless bleeding, ectopic, gastric, and pancreatic tissues naligaw napunta sa bituka, sa intestine. This is your Meckel's diverticulum. Remember your Meckel's rule of 2. Okay? 2% of the population, 2 years more common, 2 times more common in male. 2 years old is the age of presentation. The defect is usually 2 inches long, located 2 feet from the ileocecal valve, and you have 2 tissues, gastric and pancreatic. This rule does not apply to everyone. Okay? So please remember that. Abdominal pain radiating to the back, vomiting, and fever. Most common cause in children, trauma followed by viruses. In adults, iba. Usually stones, usually toxins, drugs, alcohol. Okay? This is acute pancreatitis. Amylase versus lipase. Sabi ko sa inyo, lipase lahat. Okay? For pedia, lipase lahat. Okay? Madaling tandaan, lipase lahat. Lipase ang mas specific, rises faster, remains elevated longer. Lipase, L longer. Lipase lahat. Okay? Most valuable serologic marker for acute hepatitis B infection. It is your anti-HBC antigen. Bakit? Meron siyang IgM, IgG. Siya lang yung nagpa-positive during the window stage, yung IgM. Okay? Nephrology. Sources of hematuria. Okay? Hematuria, ang cutoff natin for centrifuge urine is 5. Okay? Sources of hematuria. Pag T-colored, mataas yung protein at dysmorphic, malamang glomerular. Pag gross hematuria, gross blood, yung protein mababa at normal yung morphology. Pag sinilip sa microscope, yung mga red blood cells, hindi siya dysmorphic. Normal yung morphology. This is lower urinary tract. Okay? HOHA. Diba? Mnemonics natin, HOHA. Pag HOHA, glomerulonephritis. Pag pale, nephrotic syndrome. Again, ang pinaka-importante is hematuria. When you have hematuria, think of glomerulonephritis. When you have proteinuria, ito yung pinaka-importante, think of nephrotic syndrome. Okay? One minute. All right. Kapag glomerulonephritis, your top differential in children is your post-strep GN. Remember, pyogenes. It's your strep pyogenes. Okay, other name, group A beta hemolytic strep. Infection from pharyngitis or pyoderma. I'll make a correction, guys. Sabi ko sa exam, kapag rheumatic fever, sore throat lang. Okay? Hindi tayo nagkakaroon ng rheumatic fever, sabi ko, kapag pyoderma. Actually, that is wrong. Okay? I'll make the correction. Pwede. Pwede pero rare. Okay? You rarely get rheumatic fever from pyoderma. Pwede pero rare. Okay? How do you document infection? Pag throat, ASO. Pag skin, your anti-deoxyribonuclease B. C3 level is decreased. Tatlo lang naman yung bumabagsak yung C3, PSGN, SLE, MPGN. Tatlong renal causes, renal insufficiency. Okay? And again, remember, between or among the three, si PSGN lang ang fully nephrotic ang presentation. Si SLE sa kasi MPGN, pwede siyang mixed nephritic, nephrotic. Si PSGN, glomerulonephritis lang siya. C3 should normalize in 8 weeks. Otherwise, if hindi pa rin normal after 8 weeks, hindi na yan PSGN. Protein excretion and hypertension, 4 to 6 weeks. Wag malilito. Okay? Dok, may proteinuria pala? Pwede, konti. Pero hindi ganun karami. Okay? Mababa lang. Usually +1, +2. Acute phase in 6 to 8 weeks. Hematuria is long. Pwedeng 1 to 2 years. Okay? Let's now go to nephrotic syndrome. Okay? Sa nephrotic syndrome, ang hahanapin is proteinuria. Sa dipstick, dapat +3 pataas. Okay? +3 pataas. Hindi pwedeng less than 3. Okay? But the more accurate measurement is UPCR or 24-hour urine protein. UPCR more than 2, 24-hour more than 40 kapag ang pinag-uusapan is BSA per hour or more than 3.5 grams total in 24 hours. The most common cause is minimal change disease. It responds to steroid 95% of the time. If non-responsive, you do your biopsy and probably you will get focal segmental glomerulosclerosis, okay? By virtue of incidence, okay? Pag minimal change na hindi gumaling sa steroids sa bata, malamang focal segmental yan. UTI manifests only with fever, vomiting, diarrhea, anything and everything under the sun, that is pyelonephritis. Does not cause fever, does not cause injury, that is cystitis. Most common organism are your colonic bacteria, E. coli, Klebsiella, and Proteus. Most of them are ascending infection. The gold standard for diagnosis is urine culture. And the drug of choice, usually for outpatient management, uncomplicated UTI, is cefuroxime or co-amoxiclav. For complicated UTI, we start with our third generation cephalosporin, ceftriaxone. If there is Pseudomonas, if you're entertaining Pseudomonas, you add your amikacin or you add your fluoroquinolones. Okay? Microangiopathic, hemolytic anemia, renal failure, thrombocytopenia, RAT. Ano yung RAT? Hamburger, HUS. Hemolytic uremic syndrome, trigger. Anong pinaka-common na trigger na HUS? EHEC, enterohemorrhagic E. coli. Next, Shigella, Shiga toxin. Okay? Microangiopathic anemia, thrombocytopenia, renal failure, pero may neurologic manifestation, may fever, more common in adults. This is your TTP. Thrombotic, thrombocytopenic purpura. Acute loss of kidney function leading to rapid decline of GFR. This is the definition of acute kidney injury. And if you have kidney damage for more than 3 months or more, you call that chronic kidney disease. Sorry, kailangan mag-post. Okay, tuloy tayo. Hematology and oncology. Anemia, okay? Anemia with increased reticulocyte count, this is the expected response. Think of hemolysis or hemorrhage, okay? Anemia with decreased reticulocyte count, think bone marrow pathology. If normocytic, then probably there's bone marrow damage or decreased stimulation. If micro or macro, think of maturation disorder. Ano yung mga yun? IDA, thalassemia, folic acid deficiency, and vitamin B12 deficiency. Okay? So yun yung mga maturation disorder. Walang tama yung bone marrow pero hindi sila makapag-produce ng red blood cells for whatever reason. Okay? So again, remember, dapat pag may anemia, dapat tumaas yung reticulocyte count. Pag hindi siya tumaas, pag bumaba siya, think of bone marrow pathology. Microcytic anemia, our mnemonics is CLITS. Okay, chronic disease initially is normal, but eventually becomes micro. Okay, lead, IDA, thalassemia, sideroblastic. Macrocytic, B12 or folic. How do you differentiate? B12 has neurologic symptoms, folic does not. Most common cause of anemia in infancy and childhood is iron deficiency anemia. In IDA, your TIBC is increased versus in chronic disease, it is low. in IDA, your red cell distribution width is increased. Meaning, the sizes are varied. May malaki, may maliit, may malaki, may maliit. Versus thalassemia, your RDW in thalassemia is normal. Okay? So, yan yung mga clues on how to differentiate the two. Okay? Okay, sige. May tanong tayo dito. Good evening, Doc. Wondering how to differentiate ASD. So I hope you're talking about autism spectrum disorder versus GDD versus intellectual disability. Okay? Sige. Different terms, okay? Usually, ang nalilito yung mga students, yung ASD, autism spectrum disorder, saka yung global developmental delay. Okay? Kasi pag sinabing global developmental delay, guys, pag sinabing global developmental delay, you have delays in 2 or more spheres. Ano ba yung mga sphere natin? Motor, tapos language, tapos sa language may receptive saka may expressive, okay? Tapos motor. So fine language, receptive, expressive, tapos motor. Pag 2 or more yung delay mo, 2 or more spheres, ang tawag doon GDD. Bakit nalilito? Nalilito yung mga students kasi sa autism spectrum disorder, common din yung GDD. Okay? Technically speaking, yung mga severe, yung may mga autism, may mga ASD, pwede silang magkaroon ng GDD. Pwedeng part siya ng ASD. Okay? Very common ang language delay sa kanila. Very common ang intellectual disability sa kanila. Okay? However, what clinches the diagnosis of autism? Sa autism, kailangan yung spheres na deficient dapat present sa kanila. Ano yun? Dapat meron silang differences, dapat meron silang tawag nito. Dapat meron silang deficit in communication and interaction, and dapat meron kang restricted repetitive behavior. Okay? So, kapag linabas sa exam, may GDD yung pasyente, pero meron din siyang mga deficits in communication, interaction, tapos meron siyang stereotypical behaviors, yung mga repetitive, naglilinya ng kotse, naglilinya ng train, mas magandang sagot yung ASD. Kasi technically, it's a bigger umbrella, pwedeng nakapaloob doon yung GDD. Malinaw? So, pwede kang may ASD na may GDD. Okay? Kasi kung GDD lang yan per se, usually wala yan yung mga stereotypical behaviors. Usually, wala yan yung mga walang eye contact. Wala yan yung mga hypo or hyposensitivity to your sensory inputs. Okay? Yung intellectual disability, ID, it's actually just the new term for MR, for mental retardation. We no longer use the term mentally retarded. So, ang clinical term dyan is intellectual disability. So, pag sinabing intellectual disability, ang mini-measure lang is yung intellect, IQ. Usually, it's the IQ. Okay? All right. So, hopefully, I was able to clear up that question. Okay? Management of anemia. Okay? Management of IDA, you give your iron therapy. For thalassemia, folic acid, transfusion, and if pangit talaga, severe yung thalassemia, splenectomy. Okay? Alpha thalassemia has 4 subtypes depending on ilang focus or foci yung involved. Silent, mild, hemoglobin H, the more severe type, or high drops. Beta, dalawa lang. Major or minor. Okay? Abnormality in spectrin, nawawala yung biconcave shape, resulting in splenic destruction. This is your spherocytosis. Siya lang yung sakit na usually mataas yung MCHC. Sa board exam, ang turo sa atin, pag mataas yung MCHC, think of spherocytosis. The test is osmotic fragility test. Hemoglobin S, susceptible to polymerization, nawawala yung flexibility. Ang nangyayari, nagkakaroon ng occlusion. Nagbabara yung red blood cells. Sickle cell disease. Kaya ang manifestation niya, painful vaso-occlusive crisis. Pag nagbara siya, sumasakit yung mga organs kasi namamaga, nawawalan ng blood supply, nagkakaroon ng hypoxia. Wilms versus neuroblastoma, nasabi na natin to. Both are 2 to 5. Renal in origin si Wilms, si neuroblastoma kung saan-saan siya pwedeng tumubo. Pero ang top 2 is adrenals and your sympathetic ganglia. Wilms does not cross the midline. Neuroblastoma crosses the midline. Wilms dahil renal, konti lang ang associated symptoms, hematuria, hypertension. Neuroblastoma, sandamakmak, iba-iba, nakakalito. Okay? Metastasis, Wilms is lungs, neuroblastoma is bones. Diagnosis, important kay neuroblastoma, BMA, urine VMA, and HVA. Management, pretty much the same. The most common malignancy in children is leukemia. Among your leukemia, it's ALL. On peripheral blood smear, you have pancytopenia and hypercellularity versus aplastic anemia where you will have hypocellularity. PE findings in ALL, signs of infiltration. In aplastic anemia, there are no infiltrative signs. That's how you differentiate the two clinically. Okay? Ano ba yung signs of infiltration? Okay, ano yung mga signs of infiltration? Lymphadenopathy, bone pain, organomegaly. Bone marrow in ALL, blasts and hypercellularity versus in aplastic anemia. So AA is aplastic anemia. Fatty infiltration and hypocellularity. Prognostic factor, the best three would be treatment, age, and leukocyte count. Among the three, ang pinaka-importante, the most important is treatment. Site of spread, huwag kakalimutan, liver, spleen, lymph nodes. Anong difference? Spread is metastasis. Relapse is gumaling ka, tapos bumalik ulit yung sakit. Pag relapse, saan mo hahanapin? Bone marrow, central nervous system, and testicular relapse. Kaya usually guys, pag yung mga leukemic patients nagkaroon ng relapse, automatic yan, nagbo-bone marrow biopsy, saka naglo-lumbar tap to check for leukemic cells. Poor prognostic factors, less than 1, more than 10. Lalaki, more than 50,000 ang WBC, CNS leukemia, and mediastinal mass. Again, inuulit-ulit ko yan guys kasi lumalabas palagi sa exam. Lymphoma, regional ang spread, bimodal ang age, this is Hodgkin. Most common in children and adolescents, systemic, kalat-kalat, may organomegaly, this is non-Hodgkin. Most common solid tumor are your brain tumors. So again, remember the sequence. Leukemias, which is ALL. Susunod is brain tumor. After brain tumor, susunod si neuroblastoma, saka si Wilms. Okay? Bone tumor, metaphysis, sunburst, spindle cell. This is osteosarcoma. Pag diaphysis at onion skinning, think of Ewing sarcoma. Okay? All right. Okay, so far, let's go now to neurology. Okay. Paroxysmal time-limited changes in motor activity and or behavior. Pwedeng motor, pwedeng behavior. Because of abnormal electrical activity in the brain, this is the definition of seizure. Predisposition to generate seizure, this is what you call epilepsy. But remember, bago mo sabihing epilepsy, you have to have 2 or more unprovoked, walang trigger, unprovoked seizure, and dapat 24 hours apart. If the initial seizure is limited to one part of the brain, we call that focal. If the whole brain goes into seizure sabay-sabay, we call that generalized. Okay? Continuous activity without regaining consciousness, more than 5 minutes. This is the operational definition of status epilepticus. Meaning, pag more than 5 minutes na yung seizure mo, kailangan mo nang mag-operate. Kailangan mo nang mag-intervene. Because pag more than 5 minutes na yung seizure, there's a very high chance that this patient will go into status. Ano bang definition ng status? 30 minutes. Okay? 30 minutes of seizure or either continuous na 30 minutes or pwedeng hindi continuous pero walang regaining of consciousness. Sorry guys, nawala tayo. Okay? So again, status epilepticus by definition is 30 minutes na continuous or kahit hindi continuous kung walang regaining of activity. Pero kapag more than 5 minutes na, that is what you call your operational. Kailangan mo nang mag-intervene. Okay? Blood workup for patients presenting with seizure, what do you check? HGT, hypogly can cause seizure. Hyponat, okay, calcium, magnesium, phosphorus, blood gas to check for acidosis, and AED levels. Ano yung AED? Anti-epileptic drug. So if your patients are on maintenance, you have to check their levels. Baka kaya yan nagsiseizure dahil bumabagsak. Okay? Lumbar tap. For patients with first febrile seizure, the cutoff is 18 months. Huwag nalilito. Okay, nalilito kasi guys sa Nelson's, actually sabi ni Nelson's in Western guidelines, kapag 6 to 12 months yung pasyente at nag-seizure siya, actually optional siya. So kunwari wala kang signs of meningitis, well yung bata, wala siyang previous antibiotic intake, pwede mo siyang hindi itap. Sa Pilipinas kasi guys, common knowledge na lahat ng less than 18 months pag first febrile seizure, dapat tinatap yan. Okay? The reason is, pag less than 18 months, mahirap sabihin based on your physical exam kung may meningitis yan or wala. Okay? So, Doc, ano ba talagang susundin sa exam? We have agreed, okay, that for top-notch guys and for the board exam, ang isasagot ng ating mga students is yung 18 months. Bakit? General knowledge. Okay? Lahat halos ng doktor sa buong Pilipinas, yan yung alam. Okay? Bihira yung nagbabasa ng Nelson's, bihira yung sumusunod dun sa AAP guidelines na 6 to 12 months, bihira yun. Okay? So, to be safe, to play it on the safe side, ang sagot natin 18. Okay? Major risk factor for febrile seizure, age less than 1. If your fever is less than 24 hours, tas nag-convulsion na siya agad, and pag sobrang taas ng fever, there's a high probability na umulit yung seizure na yan. When to do LP? Ito. Okay? If less than 6 months with fever and seizure, or if ill-appearing, any age, if with symptoms of concern, meron kang Babinski, meron kang clonus, meron kang nuchal rigidity. Sabi dyan, optional, if deficient in Hib vaccine or strep pneumo immunization. So again, this one is the guidelines from Nelson's and from AAP. This one is your PPS. Although outdated, I would advise you guys na pag sa exam, lumabas yung choice na 18 months, I would advise that you choose this answer. Okay? Meningitis, rare before 9 months and after 5. Febrile seizure, generalized, not more than 15 minutes, normal PE. Okay? Occurs only once in 24 hours. Ang tawag dyan is simple febrile convulsion, also known as your benign febrile convulsions, BFC. Okay? Kapag hindi pasok dito, kapag umulit siya, more than 15 minutes, may PE findings, then ang tawag na doon is complex febrile convulsion, CFC. The most common etiology of central nervous system infection in children is tatlo, NHS. Ang mnemonics, National High School. Okay? National High School. Neisseria meningitidis, H. influenzae, strep pneumo. Okay? Duration of treatment. Neisseria, 7 to 10. H. influenzae, 10 to 14. Strep pneumo, usually 14 to 21 days. Okay? Immediate management in patients with active seizure. Again, pag nasa choices yung airway, breathing, circulation, yun ang uunahin yung isagot. Yes, of course, you have to give your short-acting benzodiazepine. Drug of choice is midazolam or diazepam. But kung papipiliin, dalawa yung choices, diazepam or manage your airway, breathing, and circulation, the better answer is ABCs. Okay? CSF findings in meningitis. Pleocytosis, maraming cells. Usually, WBC yung mataas. Usually, neutrophils yung mataas. Elevated protein and decreased sugar. Okay? Should you do blood culture in patients suspected for CNSI? Yes, because 80 to 90% of the time, you can isolate the organism because pag tinanong kayo, usually tatanungin ng pasyente yan, Doc, saan ba nanggaling yung meningitis ng bata? 80 to 90%, hematogenous spread, blood infection. Okay? So usually from a distant site. Kunwari, nag-pneumonia yung bata, kumalat sa dugo, meningitis. Okay? The drug of choice for N. meningitidis is penicillin. Prophylaxis, you give rifampicin or ceftriaxone cipro pag mga mas matatanda. Diffuse adrenal hemorrhage, vasculitis, DIC. You see this as a complication of meningitis. This is what you call your Waterhouse-Friderichsen syndrome. Okay? In fulminant cases of meningococcemia. The most severe form of neural tube defect is myelomeningocele. All of the layers are affected, the skin, the bone, and the spinal cord. Okay? Prevention of neural tube defect, laging tinatanong sa exam, you give your folic acid, wag pagpapalitin yung dosage, nilagay ko na siya dyan para hindi tayo malito. 0.4 mg once a day. Kapag may history of neural tube defect, 4 mg once a day. In microgram, that is 400 and the other one is 4,000. So please write that down, please memorize para hindi nyo mapagpapalit. Seizures, mental retardation, shag green patch, okay, periungual fibroma, candle dripping on imaging. This is tuberous sclerosis. Kapag cafe au lait macules, axillary freckling, associated with optic glioma, and ang problem is nasa chromosome 17, think of your neurofibromatosis. So may diagnostic criteria, please balikan sa handout and i-memorize nyo yun. Okay? Let's go to pulmonology. Stridor, viral etiology. Pag virus, usually may prodrome. Hoarseness. And this one responds to racemic epinephrine. When you do your imaging, you see your steeple sign, which is a form of subglottic narrowing. This is your laryngotracheobronchitis. You have to differentiate it from epiglottitis. Epiglottitis is more toxic. Okay? More toxic. It is bacterial. You need antibiotics. Hindi gagana yung racemic epinephrine. In epiglottitis, ano yung nakikita natin? You see your thumbs up, thumbprint sign. Okay? So thumbprint. Most common foreign body in children is nuts. The top 3 organism for rhinosinusitis, strep pneumo, Moraxella catarrhalis, and H. influenzae, non-typable. The drug of choice for rhinosinusitis is your amoxicillin. Pwede pa rin, pwedeng amoxicillin. Okay, high dose amoxicillin. Management for acute bacterial rhinosinusitis, ayan, sinabi na natin, amoxicillin high dose or co-amoxiclav. Rugged tracheal air column, staphylococcus. Think of bacterial tracheitis. Drug of choice for pertussis, okay, presents with paroxysmal cough, tapos tuloy-tuloy yung ubo, namumula na yung muka ng bata, at the end of the coughing, nagkakaroon siya ng expiratory whoop, okay? Ganun, kulang siya ng hangin. This is pertussis. The drug of choice is azithromycin. Wheezing, less than 2 years old with fever, and other household member with the same illness. Think of bronchiolitis, okay? Baka hindi yan asthma, less than 2. Tapos may sakit pa yung mga tao sa bahay. Remember, not everything that wheezes is asthma, and not all asthma will wheeze. Drug of choice for asthma, it's your inhaled corticosteroid. For acute exacerbation, it's SABA plus inhaled corticosteroids. Okay? Dati, sabi ng Gina, SABA lang. 2020 onwards, bago na yung recommendation, guys. Hindi na tayo nagsasaba only, higher mortality and morbidity, higher hospitalization. Dapat palagi ng may steroids. Okay? Inhaled corticosteroids or oral, pero usually inhaled ang binibigay. Pneumonia with consolidation, think of strep pneumo. Pneumonia with air leaks and pneumatocyl, automatic staphylococcus yan. Okay? And right middle lobe syndrome. Pag nasa right middle lobe yung pneumonia mo palagi, hindi nawawala, may chronic cough, weight loss, and adenopathies, think of tuberculosis. X-ray pa lang, may differential diagnosis ka na. So please remember that. Consolidation, very common in strep pneumo. Pneumatocyl, very common in Staph aureus. Okay? Across all age group, pag tinanong anong pinaka-common na cause ng pneumonia, it's your viruses. And again, the trend in children, in pediatrics, pag ang tanong sa inyo, most common cause, at merong viruses sa choices, malamang viruses yan. Maraming sakit sa bata na ang number 1 etiology are viruses. Okay? Most common bacterial pneumonia, yan na yun, iba na yun, sinabi na niya sa inyo, bacterial, strep pneumo yan. Most common cause of ORT is rhinovirus. The drug of choice for PCAP-A is amoxicillin. The drug of choice for PCAP-C, depending on your immunization status. Pag fully vaccinated ka, pwedeng fully immunized ka, pwedeng ampicillin. Pero, pag fully immunized ka, pwedeng PenG. Pero pag hindi ka fully immunized, kailangan ampicillin to cover for your HIB. Okay? And again, when do you consider changing antibiotics? Kailan ka mag-step up if walang improvement in 48 to 72 hours. And this goes through not just for pneumonia, even in other diseases. UTI, okay? In general, ganyan yung trend. Pag walang improvement in 48 hours, re-evaluate. Pathogens should you consider in patients with pneumonia 5 years and above? That is your atypical pneumonia. Drug of choice, your macrolides, azithromycin, clarithromycin. Cutoff for PPD. Remember, in general, the cutoff is 10. Okay? So abroad, sa States, ang cutoff nila 10. Pero, if you have risk factors, ano yung mga yan? Immunocompromise, exposure, x-ray findings, or signs and symptoms. Pag may risk factors ka, 5 lang positive na. By virtue of being a Filipino, okay? By virtue of living in the Philippines, where majority are exposed to tuberculosis, most of the time, ang cutoff na ginagamit sa Pilipinas, 5. Okay? GON complex is composed of 4 things. Your pulmonary focus, regional lymph node, peritracheal lymph node, and localized pleurisy. Okay? And how many out of the 5 parameters should be fulfilled to diagnose TB? Dapat 3. Okay? Ano ba yung 5 yon? Exposure, PPD, signs and symptoms, X-ray, other tests. Okay? So exposure, PPD, signs and symptoms, X-ray, saka other tests. Ano yung mga other tests? Gene expert, TB culture, okay, IGRA, okay? All right. Treatment, regimen 1 or regimen 2 lang yung kailangan tandaan for exam. Okay? Keyword, regimen 1, hindi kasama ang CNS, bones, or joint. Regimen 2, kasama yung CNS, bones, or joint. Pag TB of the brain, TB of the bones and joints, regimen 2 ka. Okay, so 2 HRZE, 4 HR for regimen 1, 2 HRZE, 10 HR for regimen 2. Hindi yan HRR ha, HRZE lang yan. 2 HRZE, 10 HR. Whether new or retreatment, as long as expert is sensitive or indeterminate. Or new cases na walang expert na nagawa, ito ang regimen. Most of the time, ito ang tatanungin sa exam. Okay? So, ito, for personal consumption lang to, ito rin naman yan guys. Okay? Ito lang yung mas detailed na makikita nyo sa DOH 2020 National TB Control Program Handbook. Alright? Let's now go to rheumatology. Kawasaki, how many days of fever? Dapat at least 5. How many criteria? Dapat at least 4. Ano yung 5 yon? Namumula from head to toe. Namumula yung bata from head to toe. Conjunctivitis, rash, adenopathy, tongue, hand, and foot changes. Remember for Kawasaki, dapat hindi vesiculopustular. Dapat hindi exudative. Dreaded complication is your aneurysm. What phase? During the subacute phase. Usually after 14 days because your acute phase is 10 to 14 days. Subacute is around 10, 14 onwards. Okay? Treatment, you give your you give your IVIG plus aspirin. Dapat anti-inflammatory dose. Okay? So high dose aspirin. Laging tinatanong sa exam, when do you do your 2D echo at diagnosis? After 2 to 3 weeks. If normal, repeat after 6 to 8 weeks. If abnormal, we repeat earlier. Persistent fever after 36 hours. Nag-IVIG ka na naglalagnat pa rin, that is what you call IVIG resistant Kawasaki disease. Kaya anong gagawin? Isa pang IVIG. Pag hindi pa rin gumana, anong gagawin? Usually other modalities such as methylprednisolone. Gotron papule, heliotrope rash, myositis, okay? Abdominal muscle weakness, Gower sign. So these are what you call your dermatomyositis. These are your neurologic problems na may kasamang dermatologic manifestation. Kalimutan ko na yung general term. Balikan ko mamaya. Okay? So this is juvenile dermatomyositis. Papules, Gotron, heliotrope rash, myositis, proximal muscle weakness. Okay? Palpable purpura, abdominal pain, joint pain. Okay? It is the most common cause of non-thrombocytopenic purpura, meaning normal yung platelet pag chinek mo. This is your Hinoch-Schönlein purpura. Okay? IgA-mediated vasculitis of your small vessels versus Kawasaki. Kawasaki is medium-sized vessels. Ang Hinoch-Schönlein is small vessels. Okay? Treatment is supportive. Hindi lahat ng HSP nagbibigay ng steroids. But if your patient has severe symptoms, severe abdominal pain, or nagkaroon siya ng glomerulonephritis na pangit, then you can opt to give your steroids. But for most cases of HSP, it is supportive. Hindi ko talaga maalala yung term kung anong tawag dun sa group of diseases nitong mga to. Yung meron kang dermatologic plus neurologic manifestation. Message ko na lang kayo, guys. Okay. Less than 16 years of age, meron kang arthritis. Okay? And your onset is defined kung ilan yung tinatamaan. Ang tawag dyan, juvenile idiopathic arthritis. Dati, ang tawag JRA, juvenile rheumatoid arthritis. Ngayon, JIA na siya. Remember, pag 4 or less joints, that is oligoarthritis. Pag 5 or more, that is polyarthritis. And pag may rash and fever, think of your systemic onset arthritis. Okay? Autoantibody production resulting in inflammation of basically the whole body, halos lahat ng organ system. Pero common sa skin, sa joint, blood-forming cells, blood vessels, and CNS. This is your systemic lupus erythematosus. The most sensitive test is your ANA. You use it for screening. But for specific, we look for your anti-dsDNA or your anti-SMIT. Anti-SMIT is only found in SLE. Please remember that. All right? Let's now go to cardiology. Right? Cardiology. Your closure of ductus arteriosus is usually 10 to 15 hours. This is the physiologic closure. The anatomic closure is usually 2 to 3 weeks. Madaling tandaan, 14. Okay? 14 hours is closure na physiologic. 14 days ang closure na anatomic. The most common acyanotic congenital heart disease is your VHD. The most common cyanotic is your TOF. TOF presents with delayed onset of cyanosis. Usually, months na yan. Medyo malaki na yung bata. Pero pag early onset cyanosis, think of transposition of your great arteries. Okay? Systolic ejection murmur on the second ICS, right-sided enlargement. Pag right-sided, tapos ejection yung murmur, think of ASD. Kapag left-sided, tapos regurgitant, think of VSD. Okay? Ilan-ilan lang ang sakit na merong regurgitant murmur sa LLSB. Okay? Sa left lower sternal border. Ano lang yung regurgitant murmur na yan? Ilan-ilan lang yan. VSD, MR, saka TR. Okay? VSD, MR, and TR. If it is rheumatic, that is mitral regurgitation. If it is congenital, then probably that is VSD. Tricuspid regurgitation, very rare. Okay? Continuous machinery-like murmur, bounding pulses, this is your patent ductus arteriosus. Remember, TOF, kailangan alam natin because it's the most common congenital heart disease na cyanotic. Component is prove. You have to prove that you have a TOF. Pulmonary stenosis, right ventricular hypertrophy, overriding aorta, VSD. The most important lesion is your pulmonary stenosis, your right ventricular outflow tract obstruction, because your pulmonary stenosis determines the degree of cyanosis. And sa TOF, natitrigger tayo ng TET spell. Remember, what triggers TET spell? Catecholamine release and decrease in your systemic vascular resistance. Guys, ang daming nalilito, and I think I have explained or I will explain this in detail during my, if not mistaken, maybe bonus lecture yata or sa Pearls. Okay? Guys, para hindi kayo malito, huwag niyong pagpalitin yung SVR na systemic vascular resistance saka systemic venous return. Okay? Sa TET spell, ang problema natin is decrease in your systemic vascular resistance at increase in your systemic venous return. Pag pinagsama mo yon, natitrigger yung TET spell. So how do you address that? Baliktarin mo. You give your phenylephrine, your vasoconstrictor, to increase your systemic vascular resistance. Yung SVR na tinutukoy nyo dun is systemic vascular resistance. Again, decrease in your vascular resistance triggers the TET spell. To abort the TET spell, you want to increase your systemic vascular resistance. Kabaliktaran ang venous return. Pag mas maraming venous return to the heart, mas nagte-TET spell. Okay? So ang gusto mo is to abort the TET spell, gusto mo yung venous return mas konti. And that's why you do your knee-chest positioning. Okay? You give morphine to calm the patient. You give oxygen to address your hypoxia, and bicarb to address your acidosis. You can also give propranolol to address the spasm of your right ventricular outflow tract. Huwag mag-alala. Again, I will have a discussion, very detailed discussion on this para hindi kayo malito. Miscellaneous CHD. Early onset cyanosis, increased pulmonary blood flow, egg-shaped heart, that is your toga. Weak or delayed, hindi yan dilated. Weak or delayed or absent femoral pulses. Blood pressure is higher in the arms or in the legs with rib notching, think of coarctation. The typical location of your coarctation is the descending aorta distal to the origin of your left subclavian vein. Remember, for your rheumatic heart disease, you have to have 2 major or 1 major plus 2 minor. Okay? Required ang evidence of strep infection. And yes, pwede sa skin pero madalang. Major is joints, carditis, nodules, erythema marginatum, and Sydenham chorea. Arthritis is usually polyarthritis. It's usually migratory. Carditis, you see that in 2D echo or pwede ring subclinical. Okay? Pag sinabing subclinical, wala siyang murmur pero meron siyang findings sa 2D echo. Nodules, saan siya? Usually sa extensor surfaces. And again, Sydenham's chorea, this is the standalone criteria. Pag meron kanyan, malamang rheumatic fever yan. Minor is frappe, fever, risk factor, arthralgia, prolonged PR interval, also known as your first degree AV block, and increase your acute phase reactance. Okay? In rheumatic fever, migratory polyarthritis, sinabi natin kanina, large joints, and very important, they respond to salicylates. Pag nagbigay ka ng aspirin, nababawasan or nawawala yung pain. The classic findings on auscultation, ano ba hinahanap? Usually sa rheumatic heart disease, mitral regurgitation. So MR, how does it present? Again, regurgitant holosystolic murmur on your left lower sternal border. Wala kang auscultatory findings, pero pag check mo sa 2D echo, meron. Yan yung subclinical carditis. Erythema marginatum, it is serpiginous erythematus. Never on the face, disappears pag malamig, lumalabas pag mainit. Sinabi na natin to kanina, the diagnosis of recurrent. Huwag malilito. Ito, first diagnosis. Dapat 2 major or 1 major plus 1 minor. Pag recurrent na, ganun pa rin, pero in the Philippines, in areas where there is high risk for rheumatic fever, okay? In areas na maraming rheumatic fever, 3 minor pwede na for recurrent RF. Not the first diagnosis, but for recurrent RF. How do you eradicate your group A strep infection? 10-day course of penicillin or 1 dose IM. Okay? Anti-inflammatory agents are also given, aspirin or prednisone. And for prophylaxis, these patients will go on a long-term journey of monthly injection. Okay? Kawawa. Eventually, masasanay na sila. Buwan-buwan tinutusok yung puwet nila. PenG every 21 days. Okay? Dok, akala ko 28. Okay? Recent guidelines, 21 na guys. So, mas maikli na. Okay? So, remember the difference between your innocent and your pathologic murmur. Hindi natin dadaanan yan. Let's go to infectious diseases. Neonatal conjunctivitis, usually it's your gonorrhea, chlamydia, and pseudomonas. In older children, think of viruses. Adenoviruses, staphylococcus. Kapag may inclusion body, think of chlamydia. Skin infection in children, most of the time, it's either staph or strep. Okay? Itong batang to, nakagat ng insect, tapos kinagat niya, kinamot niya. Tapos kumalat. Nagkaroon na ng erythema at blistering. Tapos, ang predisposition niya is your periorificial area. Periorificial, sa paligid ng mga orifice. So, sa bunganga, sa ilong, sa umbilicus, sa puwet. This is your staphylococcal scalded skin syndrome, also known as your Ritter disease. Sa isang exam, wala yung choices, yung SSSS. Ang tanong, Ritter. Yun yung lumabas sa choices. The drug of choice is Oxa, if MRSA, Vanco, or Clinda. Again, if methicillin-sensitive, Oxa, if MRSA, Clinda, or Vanco. Viral exanthems, you have to differentiate this. Dapat automatic, dapat hindi na malilito. Nung med school student ako, litong-lito ako dito after ng lecture ni Dr. Ruby, ang dali lang pala. Cough, coryza, conjunctivitis, rash at the peak of fever, cephalocaudal, nagdedesquamate, that is measles. Shorter duration, you call this your 3-day measles. Cephalocaudal din siya. Pero ang hahanapin nyo, posterior lymph node, this is rubella. Okay, measles, look for 3C. Rubella, look for the posterior auricular lymph nodes. Okay? Ilan lang ang sakit na pag nawala yung fever, saka lumalabas yung rashes. Pag nawala yung fever, saka lumabas yung rashes, this is roseola. Okay? Different lesions, different stages, all present at the same time, this is varicella. Slap cheek appearance, para siyang sinampal. Okay? It spares the palm and the sole. This is your fifth disease or your erythema infectiosum. Dengue fever. Okay? Look for thrombocytopenia, hemoconcentration, but these two findings, you see this later on and pag may complication. A lot of times what you will see would be leukopenia. Mababa yung WBC. Remember the warning signs for dengue kasi pag may warning signs yan, those are indication for admission. The pathophysiology is increased capillary permeability. Yung capillaries nyo guys, nagli-leak. Dahil nagli-leak, lumalabas yung plasma, kaya nagkakaroon ng hemoconcentration. Kaya nagkakaroon ng thrombocytopenia. Anong mas nakakatakot sa dalawa? Malayong mas nakakatakot yung hemoconcentration. Bihira kang mamatay sa thrombocytopenia. Ang nakakamatay is hemoconcentration. Pag malapot yung dugo, pwede siyang mag-shock. Okay? The first 3 days of fever, the best test is NS1. 5 days onwards, that's when you do your dengue blood, your IgM. Management is supportive, fluid and hydration and monitoring. Okay? AIDS, the vertical transmission can happen via intrauterine transmission, intrapartum, or postpartum. Ang tinatanong sa exam, timing of your test. For infants born to HIV-positive mother, viral testing is done on the first 2 days of life, 1 to 2 months, and 4 to 6 months. Monitoring of your CD4 and CD8, you do it at 1 and 3 months, and then every 3 months starting at 6 months of age. So please remember these, okay? So these are your viral detection assays, HIV, DNA, or RNA, culture, so forth, and so on. Okay? Parasitic infection, pinworm, the drug of choice is Pyrantel pamoate. Wuchereria, Brugia, okay, elephantiasis, think of diethyl carbamazine. Echinococcus granulosus, albendazole. Cestode, the drug of choice is praziquantel. Trematodes, it's praziquantel. Ascaris is albendazole. Okay? Ang nakita kong pattern dito, nung nag-aaral ako ng micropara, karamihan ng mga bulate, ang drug of choice ay praziquantel. Pag hindi nyo alam yung sagot, baka praziquantel yung magandang isagot. Okay? But in the Philippines, routinely, we use mebendazole or albendazole. And technically speaking, yes, covered din lahat ng mebendazole sa albendazole yung mga bulating yan. Okay? Pero sa exam, pag ang tanong, drug of choice, usually praziquantel. Okay? Endocrinology. Remember the pattern. Okay? In girls, nauuna ang telarc, bago pubarc, then growth spur. Tapos saka pala nagkakaroon ng menarche. In boys, it's gonadarch. Tapos pubarch, adrenarche, nahuhuli yung growth spur. Mas naunang tumatangkad ang mga babae kesa sa mga lalaki. And very important numbers to remember, precocious puberty is 8 in girls, 9 in boys. Pag meron kang development of your secondary sexual characteristic before 8 or before 9, you call that precocious puberty. Delayed, on the other hand, in girls is 13, in boys it's 14. Okay? Other notes, telarc, sabi ni Nelson's 8 to 12. Menses happen 2 to 2.5 years after your menarche. After your telarc. Okay? So telarc muna, after 2 to 2.5 years nagkakaroon ng menarche or your menses. Sometimes even as long as 6 years. Okay? Your peak height velocity happens at SMR 2 to 3 in girls. Again, mas nauuna. Versus the peak height velocity happens at SMR 4 to 5 sa boys. Okay. Most common cause of hyperthyroidism in children, it's your autoimmune causes. Okay. This is what you call your Graves' disease. So again, kapag hyperthyroid sa bata, think of grave. Okay. And ano yung hahanapin nyo? It's your TRS antibodies. In Graves' disease, dahil hyperthyroid siya, what do you usually see? Increased T4 and T3, decreased thyroid stimulating hormone. Kasi nga, mataas na yung T4 sa T3. And again, for Graves, look for your TRS antibodies. The definitive management is your radioactive iodine ablation or thyroidectomy. Okay? Permanent complication, of course, is hypothyroidism. So pag tinanggal mo yung thyroid, kailangan mo magbigay ng thyroid supplementation. Management for Graves is PTU or metimazole. Pag pregnant, PTU ang mas magandang gamot. Okay? Most common cause of thyroid disease in children and adolescents. It is also autoimmune, pero sa Graves TRS antibodies, ito ang hahanapin mo, TPO, thyroid antiperoxidase. Both will present with goiter, pero si Graves usually hyperthyroid. Etong sakit na to usually euthyroid. This is your Hashimoto's thyroiditis. And I guess that was my last slide, guys. Thank you for listening. Sana marami kayong natutunan. Okay, shameless plug. My channel, my humble YouTube channel is nearing 5,000 subs. Guys, like and subscribe. Magpapamigay ako ng keyboard on the 5,000 sub. Okay? Maraming salamat, guys. It has been a very busy, wonderful, and fulfilling week. Sana marami kayong natutunan. Good luck on your board exam. All right?